Very quickly, so thank you all so much for coming here this afternoon on a beautiful Friday afternoon. I'm really excited about this event. My name is Harriet Emerson, and I'm the hybrid program administrator here at the COA. So hybrid just means that programs are offered in person, such as you guys are here with us this afternoon, and also online through Zoom, which is really exciting because for whatever reason, people can't join us in person, they can join us remotely. And since this event is being recorded, thank you very much again, Jaymie. We're going to make it at some point in time, like I said, online. So folks, who are unable to join us in person or online, they can watch it later, which once again just makes it a lot more accessible. So I first heard Jaymie give a presentation earlier this year on this topic, women's health and hormones. And I was just personally really blown away. And there was just so much information that I was not aware of, I hadn't heard discussed, that my personal physician had not asked me, and a lot of information that I found myself wishing I had known for earlier. So Jaymie's been doing a lot of these community presentations, and I really appreciate her joining us today. She's a nurse practitioner at Cape Gynecology who specializes in women's health and hormones. Once again, I'm so pleased that she's here with us this afternoon. And without further ado, I'll let Jaymie start her presentation.
Thank you so much, Harriet. Thank you. So welcome to the Pelvis Party. Glad you're all here. Yeah, maybe. Pelvises can get a little cobwebby sometimes, maybe. We're gonna dust them off today. Talking about pelvises, women's health, hormones, sexual health. We all can feel a little uncomfortable. So we avoid talking about it. You can see, okay, I don't wanna, okay. And this becomes a vicious cycle. The less we talk about it, the more uncomfortable we get. The less we talk about it, the fewer words and language we have, and then it just gets harder to talk about. And this results in invisibility at lots of levels. We're gonna talk about that quite a bit today. Invisibility hurts people, it hurts women, it hurts men, it hurts healthcare providers' ability to help you. And invisibility has a lot of consequences: pain, shame, disability, job loss, loss of independent living, divorce, death. Let's get into it. Men aren't really invisible. Newsflash. A database of behavioral sciences over the last 200 years shows the word penis used more than 3 times as often as vagina, vulva, and clitoris combined. Where did my view go? There's the slang words for male genitalia vastly outnumber slang words for women's genitalia. And the National Coalition for Men claims penis, the word penis, has more synonyms than any word in the English language. The same TV networks that allow use of the word penis ban use of the word vagina. And there's all kinds of words that are built into our everyday expressions. We don't even think twice about mankind instead of people, or no man's land is someplace that's sparsely populated, right? The idea of expressions like, that's a ballsy move versus that's a pussy move. What do those two things mean, right? Now, if we apply the same amount of pressure to a pair of testicles that we do to a vagina, which one buckles first? Right, so I think we might have our connotations opposite, confused, yeah. In medicine, the field of urology is devoted to men's sexual health. Great. The field of gynecology is devoted to women's reproductive health. That's different. Medical books devote many more pages to male pelvic anatomy than females, and many surgical texts still do not include clitoral anatomy, and we're going to talk about that more. Culturally speaking, there's statues of male genitalia peeing into fountains everywhere, right? Not so many women. Religious ideas that sex is for making babies, but not for fun if you're female, right? There's a story that the British author Sarah Chadwick shares when she was a teacher. On the last day of school, the custom was that the kids would all sign each other's t-shirts. And she said as soon as the magic markers came out and they started signing their names, the boys all drew penises on the t-shirt, right? One of them brought the t-shirt over to her, she was the teacher, and asked her to sign it, and she said, sure, if I can draw a vulva. And he said, that's not allowed. And then there's the case of the Washington Monument. Am I alone in wondering where the federal Ballbar Monument is? There are negative associations for anything women go through that men don't. Periods, childbirth, breastfeeding, menopause. Even words like feminine hygiene products imply women are unhygienic because they menstruate. Men get friendly nicknames for body parts like willies and dicks and balls and nuts. Vaginal nicknames, few, far between, not very nice, right? Vulva has one nickname that no one really uses outside of medical circles. That is pudenda. Has anyone even heard that word? It is used in medicine. Pudenda is Latin for that which ought to cause you shame. I am not. And clitoris, which is the fun house, has no nicknames. Can anyone think of any? No. Yeah. And does anyone know the Greek root for the word for uterus? Anyone who's on my laptop? Anyone else? No. The Greek root for uterus is hist. That's where the words hysteria and hysterical come from.
Wow.
Yeah. So women being medically, socially, and culturally restricted is woven into everyday life. And these ideas are embedded in language, in culture, and in healthcare. And I love this quote from Mark Twain: "The very ink with which all history is written is merely fluid prejudice." So coming back to the idea of invisibility, I'm going to help everyone overcome the invisibility with hormone goggles. This is your first party favor for the pelvis party. Hormone goggles. Oh, you're just in time for hormone goggles. Come on. We're talking about visibility and invisibility in healthcare. Medical providers are taught the art of pattern recognition. So if you come in to a doctor's visit with a question or a concern, their job is to connect the dots and figure out, is this one problem? Is this more than one problem? So they can make an accurate diagnosis and then hopefully a plan that helps you, that you feel better. Medical providers recognize the patterns and connect the dots they are taught to look for in their medical training. And medical training is based in culture and language and reflects what is considered important enough to teach and important enough to learn. But what's implied by that in medical training is if it's not taught, it is not considered important. What does this say? Make that go away. So historically speaking, in medicine, we talk about evidence-based medicine as being the most sort of important because it's based on clinical trials. But looking at history, it was as recent as the 1970s, women were actively excluded from clinical trials. There was a fear of accidentally hurting a fetus. It wasn't until the 90s that a law was passed that women must be included. The 90s, yeah. And it was 2016, which was really 5 minutes ago, that a law was passed saying results from trials need to be reported based on gender. But this is not enforceable, and it is largely not enforced. Women are less than half the participants in trials in the areas that most affect women: cardiovascular disease, cancer, psychiatric disorders. So it is no surprise that women have twice the negative side effects as men in medicines and in surgical procedures. And female mice are more expensive to study than male mice. How does this affect my pelvis? You might be wondering. Well, it wasn't until 2005 that the full internal structure of the clitoris was seen with an MRI. It was found to be 10 times the size it was estimated to be. Prior to that, and last year, 2023, the nerve endings in the human clitoris were first quantified. It's found to have almost 3 times the number of nerve endings as a penis. But this was just last year. And prior to that, the nerve endings in the clitoris were based on the study of the clitoris in a cow. Yeah. This is really important because there are many gynecologic, urologic, and orthopedic surgeries that have been shown to have cut the clitoral nerve supply in women so that after the procedure, they could not have an orgasm. This isn't just a pelvic problem. Does anyone know what the leading cause of death is in women? Shout it out. Heart disease, yeah. Underdiagnosed and undertreated in women, this is widely recognized, maybe because we call women's symptoms atypical. Why? Women are 50% of the population. Because their symptoms aren't the same as men's. Men's are the standard symptoms, so women's are atypical, rendering them impossible to see. And so women die annually more often from heart disease than men. Principal investigators leading to clinical trials, cardiovascular disease, more than 80% male. We can all agree, gynecologists are the bosses of women's health. A gynecology degree takes a long time, 8 years. Anyone want to guess how much of that time is devoted to care in perimenopause, menopause, and postmenopause?
5 minutes.
She's got a thought. It's 1 to 2 hours. Yeah. How about the time devoted to sexual health in that 8 years? It's less than it's nothing. It's nothing. Yeah. Whoops, did we lose a? Yeah.
She never got rid of that one.
Oh, thank you. Thanks, sorry, yeah. So gynecology training is devoted to pregnancy, avoiding pregnancy, anything to do with pregnancy, everything to do with fertility. For today's purposes, I'm going to be referring to this as the uterus party. Now, women's bodies are different from men's in large part because of hormones. When hormones cycle monthly, that's the uterus party, you can get pregnant still. When hormones cycle erratically, that's perimenopause, the hormones are winding down. And when the hormones are gone, that's menopause. The whole body is affected when the hormones are present and cycling. And the whole body is affected when the hormones stop. So hormones are incredibly important and valuable in understanding women's health. Are they viewed that way as important and valuable? Well, if we say a woman is hormonal, this is universally recognized to be a negative statement, a put down, right? Meaning lots of connotations: dumb, like a bimbo; immoral, like a slut; unreliable, like a disability; dangerous, like a witch. Think of a lot of historical precedents here, unfortunately. We got one positive association with hormones, and that's fertility, coming back to the uterus party. Because hormones supply the drinks for the uterus party, we think of them as sex hormones. These are the hormones produced by the ovaries, and we're going to come back to this point: estrogen, progesterone, and testosterone. But estrogen, progesterone, and testosterone are not just sex hormones. They affect far more than just your uterus. They work on every organ in your body until they don't. When ovaries close up shop, that is menopause, and ovaries close up shop long before any other organ in your body does. The ovaries age 2.5 times as fast as the entire rest of your body. That's when the uterus party turns into the after party. And the after party is drama. When women's bodies shift from the uterus party to the after party, the hormones, the loss of hormones, affect every other part of the body except the uterus. But gynecologists, the bosses of women's health, aren't looking at any other part of the body except the uterus. There are hormone receptors for estrogen, progesterone, and testosterone in every part of the body, and every organ can show symptoms when the hormones cycle, right? That's the uterus party. When they falter, that's perimenopause, and when they stop in menopause. And the organs can be mild, they can be moderate, they can be severe, and they can be temporary, intermittent, or permanent. Now here's where the hormone goggles are going to start to be helpful, because pattern recognition can be tough. Gynecologists are going to have a hard time with the pattern recognition, connecting those dots if the symptoms are vague and have nothing to do with your uterus. But who's really not thinking about what's happening with your ovarian hormones in your 30s and your 40s and your 90s? The eye doctor: dry eyes, vision changes; the dentist: dry gums, loss of gum mass; the neurologist: when headaches get worse and there's memory changes; the podiatrist: when your feet hurt; orthopedist: frozen shoulder; the rheumatologist: arthritis, fibromyalgia, autoimmune disease. 4 out of 5 people with autoimmune disease are women. The gynecologist, women too, with recurrent urinary tract infections. And the psychiatrist, trouble concentrating, trouble remembering, depression, anxiety, panic. All of these symptoms can result from loss of ovarian hormones. They can also result from other things happening, but they can be attributable, sometimes 100% from the loss of ovarian hormones. Menopause is a low hormone state, and we might want to even think of it as a hormone deficiency, like we would with underactive thyroid or, underactive pancreas, type 1 diabetes. Physical and mental health conditions are misdiagnosed or misattributed in perimenopause, menopause, and postmenopausally all the time. We're going to take what is unfortunately an extremely common example. So a woman in her 80s with UTIs, that's a urinary tract infection, multiple UTIs. She's going to the emergency room a lot. She's been put on multiple courses of antibiotics. She had a secondary gut infection resulting from the antibiotics, which was contagious and caught by family members. C. difficile, very hard to treat. But her urinary symptoms did not improve despite all of the antibiotics. In fact, her urinary symptoms got worse to the point that she was not able to take care of herself. Her family was not able to take care of her, and she had to move into a nursing home. Recurrent UTIs in postmenopausal women are usually, not always, usually caused by pelvic hormone deficiency. It's called genitourinary syndrome of menopause, which is a mouthful, so we call it GSM for short. It is extremely common. 100% of women will have GSM to some degree. It is extremely serious. Women die from urosepsis every day. It is extremely expensive. In this country alone, this is more than $2 billion a year, and it is extremely preventable. We're going to talk a lot more about GSM, but we're going to pause here and go through a couple of definitions in chronological order in reverse on purpose. Postmenopause, rest of your life after menopause. We are living a long time now, so we can be living 30, 40 years postmenopausal. Menopause is one day. It's the 366th day after your last period, and that's only if you were having periods. Lots of people don't. Menopause usually happens in the 40s or 50s. In this country, the average age is 51. Perimenopause is the time leading up to menopause. This can last a really long time. So menopause is usually in the 40s or 50s. Perimenopause can start in the 30s or 40s, and it can happen sooner too. And there is not a test to tell you if you're in perimenopause. What is a hormone? A hormone is a chemical that one body part creates that acts on a different body part. A hormone receptor is a protein that catches the hormone signal to activate a cell. A neurotransmitter is a brain chemical that affects brain function. Hormones are neurotransmitters. Any medicine that contains a hormone is hormone therapy. We're going to call that HT. And there are 2 different types of HT, and they are really different. Same ingredients, but in very different dosages. Bloodstream HT, the other word for that is systemic, goes into your bloodstream. So it travels through your whole body and impacts your whole body. Interestingly, it doesn't get into the pelvic tissue very well. Whereas pelvic HT, the other word for that is local, it only affects the pelvis. So this brings us back to GSM. Maybe. Genitourinary syndrome of menopause, again, GSM, happens because of the loss of estrogen and testosterone in the pelvis. Did you know all women make testosterone? You do, yeah. The longer you are past menopause, the more of an issue this can become because it causes architectural distortion, resulting in a whole list of menu items here: overactive bladder, urinary leaking, nighttime urination that can cause insomnia in and of itself, urinary urgency, stinging with urination, with or without a positive culture for a UTI. But UTIs, recurrent UTIs, UTIs after sex, pain with sex, decreased sensation with sex, problems with orgasm becoming diminished or muted or loss of ability to have an orgasm at all, libido issues, plain old just discomfort, sitting, riding a bike, wearing certain pants, and sometimes hip pain, pelvic pain, and back pain. So we're going to take a look at GSM first without hormone goggles. Okay, what do we normally reach for? Urinary tract infection, antibiotics, right? Yeah. What happens when we give antibiotics? It kills not just the bad bacteria, but the good bacteria. This affects your gut microbiome and weakens your immune system. For you, for everyone else, it increases the rates of antibiotic resistance and the rise of superbugs. So we are seeing people all over the world dying from infections we used to be able to treat. Now, what about if the urine cultures are clear, it doesn't actually show an infection? Then we're going to call it overactive bladder. How do we normally treat those? Anticholinergic medicines. These are very commonly prescribed. Class of medicine that includes trospium, Bezicare, oxybutynin. What happens when we give people anticholinergics? Increased risk of dementia. We have a medical database. We have a medical database that's devoted to appropriate and inappropriate medications in older adults. It's called the Beers criteria. The Beers criteria clearly warns against the use of anticholinergics in adults over age 65. Who do you think are getting most of the prescriptions for anticholinergics? Women over age 65. What happens? Well, death. Women die from UTIs that become, so UTI, urinary tract infection, but they can become bloodstream infections, urosepsis. People die from this every day. Wind up in long-term care facilities. We saw our case example. Women outnumber men in nursing homes by almost 4-to-1, in part because of this reason. What are the most common reasons women go into nursing homes? Urinary incontinence, urosepsis, dementia, immobility or weakness, and osteoporotic bone fractures. All of these are long-term effects of hormone deficiency in part or in whole. But the urinary stuff is preventable and treatable with pelvic HT. So everyone put your hormone goggles back on. GSM affects all women after menopause. It can be mild, it can be severe, it can be lethal. The internal and external pelvic tissue becomes inflamed and distorted. It is progressive. It worsens without treatment and affects the vagina, the vulva, the bladder, and the urethra. It is almost 100% preventable or treatable with pelvic HT. Remember, pelvic HT does not go into the bloodstream. It is extremely low risk. If you start it, you can continue taking it for the rest of your life, and you can start it at any age. Get a little bit of perspective. At least 40% of American women are diagnosed annually with overactive bladder. There is an at least 50% increase in the likelihood of urinary tract infection over age 65. And we know GSM affects 100% of women. So everyone's getting pelvic HT, right? 7% of American women are offered pelvic HT. Let's talk about pelvic HT. It is estrogen, testosterone, or DHEA. The most common is ultra low dose estrogen. It goes in the vagina, either a cream, a pill, a suppository, a pessary, and usually you use it twice a week. You don't need blood tests for it. You don't need progesterone with it, as you would if you probably would if you were taking bloodstream HT. It works slow. It takes months to take effect. If you use it consistently, it still takes about 3 months to take effect. There's really no side effects, but if that tissue is very thin and raw, it can sting when you first start using it. This is over the counter in many countries, not here. And in fact, here, pharmacists or pharmacies tend to get real creative with their pricing on this. And I have patients come back and say, oh, they ask for $100, they ask for $200, they ask for $300, this costs $30. $30 for a tube of this cream. And I invite everyone, if you get good RX on your phone, you can always show that to a pharmacist, $30, sometimes even less, yeah. There is a warning label in there that I try and remember to tell my patients. If you open the package insert It says something in there to the effect of your doctor is trying to kill you with this medicine. And that is because the FDA requires that any medicine that contains estrogen carry the same warning regardless of dose. So for instance, if I were to give a 100-year-old woman who has never taken hormone replacement therapy, estrogen in a high dose, in a pill form by mouth, I could hurt her, could. But if I give the same 100-year-old woman low dose vaginal estrogen, I can cure her UTI, but I cannot hurt her. I cannot. Low dose pelvic HT is safe for 99% of women. Perhaps one group of women is an exception, and this is questionable, and that is someone who's having active breast cancer treatment with a specific class of medicine called an aromatase inhibitor. I'm going to talk about this briefly. Aromatase inhibitors are anti-estrogen medicine. It starves the body of estrogen, and that's how it works. It worsens GSM, and this often doesn't get talked about with the oncologist because GSM is largely already invisible. I'm actually curious, apart from my patients, who here has even heard of GSM before today? All right, we got some hands. Okay, good. Now, talking about aromatase inhibitors, depending on someone's cancer, and all cancers are different, there is not a monolith here. Aromatase inhibitors can decrease the risk of recurrence by some percentage. And sometimes that percentage is very low, is very small, but it always increases the risk of worse or severe GSM, including painful urination, painful sex, urinary incontinence, UTIs, vaginal infections, pelvic pain with sitting, standing, moving, and those are, and I say just with air quotes, just the pelvic side effects. Your pelvis was pretty invisible before breast cancer treatment. You add an aromatase inhibitor, it becomes extra invisible, or it does to me, having seen many patients, add insult to injury. And any nurse who works with breast cancer patients can tell you the divorce rate after breast cancer treatment is high. Now, reducing the risk of recurrence of breast cancer is valid, but recognizing how much physical and mental health is related to pelvic health is valid too. Now, GSM is a pelvic hormone deficiency, but pelvic circulation is part of the picture here. Circulatory issues affect the body and pelvis in dramatic ways. This is the cardiovascular system, the heart pumping and the blood vessels responsible for moving the blood around. Erectile dysfunction in men over 40 is usually caused by circulatory problems. Circulation brings nutrients and oxygen to body parts, and the function of an organ depends on those nutrients and that oxygen. For instance, heart attack is usually a blocked blood vessel in the heart, the blood can't circulate. A stroke is usually a blocked blood vessel in the head, the blood can't circulate. Erectile dysfunction is usually impaired blood flow in the pelvis. In fact, erectile dysfunction is starting to become recognized as an early marker of cardiovascular disease that precedes potentially life-threatening events like heart attack or stroke. So many in the both urology and cardiology communities think of the genitalia as the fortune-telling penis. Men and women can have impaired circulation over time, and this impacts all of our pelvises. Anything that narrows or stiffens blood vessels impairs circulation. Age is at the top of the list. We can't control that one. Arteries get tired. But other things that we do have control over that can add to the stiffening of blood vessels are increased blood pressure, increased blood sugar, increased cholesterol, which we could kind of say is increased blood fat, lack of movement, alcohol, nicotine. Interesting study that shows in men who were asked to stop alcohol for 1 month, increased rate of nighttime erections. Just saying. Circulation affects male and female sexual function in erectile tissue, which we all have. Men and women have matching pelvic organs with erectile tissue. Erectile tissue just means space that's waiting for blood. Matching organs are called homologs. Homologs are organs that begin as the same structure and the same tissue in the embryo and eventually differentiate to a male or female fetus. Homolog for the penis not the vagina. It's the clitoris. Remember, it's hard to talk about, no fun names for it. We got to work on that. But it is responsible for nearly all orgasms in women. It's kind of important. It's estimated that 25% of women will have an orgasm from intercourse. So if you are one of the people who does not have an orgasm from intercourse, it means you are normal. And in the small group of people who do have orgasm from intercourse, generally it's thought is because the clitoris, both internal and external, is closer to the vagina. So penis is kind of a 3-in-1, urination, procreation, and pleasure, but these are distributed out for women. But the clitoris is the fun one. You've got to invite it to the party. Penis is a really good PR. There's a long historical pastime devoted to shifting attention away from the clitoris and back to the vagina. I suspect it's better for men who are writing the textbooks and designing the research studies. Men have a great track record for orgasm with intercourse. Women don't, and women don't need a penis to have an orgasm. Clitorises really don't have any PR. The top 2 medical software systems used in this country do not say the word clitoris, and they say every other examinable and visible organ. This is really important. If you come to the doctor, if you come to me having like pain with sex, decreased sensation, I'm having a problem, you examine, you have to examine. If you come in and say, my elbow hurts or my nose hurts, we've got to examine you, right? And when you use the electronic medical systems, they list what you're seeing and examining, so you kind of check off. Is it normal? Is it not normal? If not, why? But it's not even listed in the top 2 systems used in this country. Similarly, sex ed in schools always talk about a penis and a vagina, not a clitoris, never. So the message is, don't get pregnant, don't get an infection, and don't have any fun. Don't enjoy it if you're female. Where does that leave the clitoris? Well, ignored. Leave it out of the medical textbooks, demeaned. Freud's lasting legacy of saying a good orgasm comes from intercourse, and it's a bad orgasm if it comes from clitoris or clitoral stimulation, or hurting the clitoris, as with female genital mutilation. If we can possibly manage to put names and have conversations around these, can we help? Yes, we can. Easier with men. There's so many treatments for erectile dysfunction. We usually start with PDE5 inhibitors, that is Viagra and all of Viagra's cousins. These increase blood flow. This is back to the idea of circulation. But there's so many non-prescription, non-medicine ways to increase circulation. Investing in your penis is investing in your heart and your brain. Increasing circulation decreases erectile dysfunction, but also heart disease and stroke. Avoiding processed foods, alcohol, nicotine, sedentary lifestyle, and even losing a little bit of weight increases testosterone, and that improves both libido and sexual function. There are other causes for erectile dysfunction. Some medicines can do it. Anxiety and depression can do it. Medicines for anxiety and depression can do it. Illnesses that affect the nervous system and some architectural issues. Of course, we have prescriptions. Viagra has been around for years. In 1998, when the first doctor published on Viagra, 90% of the responses he got were from which gender? What do you think? Nodding over there. Which gender?
And
Women.
women?
Where's ours? What are we supposed to do? Yeah. So how can we help the women sleeping with the men that we're helping with Viagra? Pelvic HT, safe for 99% of women, it increases blood flow. There's the circulation again. Increases elasticity, sensation, lubrication, arousal, orgasmic function, and stopping pain with sex. But remember, the effects aren't just for sex. It reduces urinary frequency, urgency, leaking, infections, pelvic prolapse. With women, if there's sexual issues, we've got to look at their medicines, their medicine list too. The most common class of medicine that can both decrease libido and impact sexual function are SSRIs. Those are the medicines most commonly used for depression and anxiety. Now, the age group that these are most often prescribed for, and by the way, these are much more often prescribed for women than men, and the age group most often given prescriptions, 45 to 65. Menopause, when there already can be, aren't necessarily, but can be issues with libido and sexual function. Will Viagra work in women? The answer is kinda, yeah. It still is shown to increase blood flow to the pelvic tissue. There's the circulation again in women, but interestingly, in women, it does not correspond with desire. That comes from here, right? Women commonly, but not always, have more responsive desire, whereas men commonly, but not always, have more spontaneous desire. This can create a conflict, but this is really just an outlook. And I often will use the example with patients. Some people really like eating chicken every day, and some people really like eating chicken once in a while. No one there is right or wrong, and no one should be made to feel like they are not okay if they don't want chicken every day. Like chicken when you like chicken. The whole idea is to enjoy it when you eat chicken. There are other medicines we can use for women. Bloodstream HT can help, like estrogen or testosterone. Flibanserin, the other name for that is Addyi. Bremelanotide, the other name for that is Vyleesi. A little bit Wellbutrin too. These can all help. They are safe for most people to use in combination, and with the exception of Wellbutrin, which is an antidepressant, most healthcare providers know little to nothing about them, increasing the culture of invisibility. Now, just quickly, who here has heard of Viagra? Anybody? Yeah. Who here has heard of Addyi? I'm curious, Addyi or Flibanserin? Right, yeah. So, yeah. So again, coming back to this idea with the hormone goggles, think about postmenopausal state as natural versus maybe a condition, maybe a diagnosis of a hormone deficiency that can and should be treated. I think of a story from the urologist and writer Kelly Casperson, talking about all the patients she's seen for urinary issues who were told by multiple gynecologists that their exam was normal. They couldn't figure out why they're having these symptoms. And when she reported on when she examined patients, the GSM was so severe, loss of skin, fusing over clitorises, distortion of the urethra. There's nothing normal about it. But again, people practice how they are taught, and think about what's taught and what's not taught. So there are societal ideas, politics, and religious ideas that diminish women. This seeps into medical training. Women take many of these messages on themselves, that decreased quality of life is the same as normal aging. And I hear this from women every day. Don't sleep anymore. And that's just part of getting older. Can't have sex, it hurts too much. Just part of getting older. Relationship problems, loss of intimacy, sometimes infidelity, just part of getting older. Job loss, leaving jobs, leaving careers for a variety of reasons, just part of getting older. Not hanging out with friends or doing fun things because they're afraid if they laugh, they'll pee, and not doing fun activities like going hiking or someplace where there's not bathrooms around. So avoiding really both social and healthy activities, just part of getting older. All increases in visibility. And I have a patient, a gorgeous, robust patient who may or may not be in this room, who just said to me a week or two ago, sometimes I feel so invisible. I ask my friends, want to go rob a bank? You know who you are. So we need to practice becoming visible to ourselves. There are benefits and risks of treating a condition with medicine, and there's benefit and risk to not treating a condition. And it's not just medicine, but Viagra, by the way, has risk too. You know, there's a risk of blindness with Viagra. And does anybody care? Nope. But we can't weigh benefit and risk if we don't acknowledge it's a condition. Then GSM is largely invisible. And again, to me, really interesting idea. Natural, yeah, but it's also a problem, hormone deficiency. We live way longer than we used to. Can be 30, 40 years postmenopausally. Our health span has not caught up with our lifespan. You're using your pelvis the whole time. Healthcare providers sometimes aren't helping this story. They often tell patients, don't need to see a gynecologist if you had a hysterectomy. Don't need to see a gynecologist if you're not having sex. Don't need to see a gynecologist if you don't need a pap smear. And we're going to talk for a second about pap smears because I get this question all the time. People do equate gynecology with a pap smear as if that's all that matters. And if you don't need a pap smear, don't bother. A pap smear is a test for cervical cancer. That's it. That's all it is. In this country, cervical cancer affects about 4,000 people a year. That's a lot. It's a lot. And in other countries, it's much more. But compare that with the downstream effects of GSM, overactive bladder, recurrent UTI. This affects and kills hundreds of thousands of people. So if you have a female pelvis, please bring it to the gynecologist. If your pelvis is prime real estate, you are using it, whether or not you're having sex. The roommates there are the bladder and the colon, and they are, as we like to say, codependent. For instance, they all have an effect on each other. If you have any chronic constipation, this can increase or cause a pelvic organ prolapse, and that increases your risk of overactive bladder and urinary tract infections. So what can we do for our pelvises? Eat real food. Unprocessed foods, fiber, more fiber, more fiber, and more fiber. Americans get less than half of what they need. And unfortunately, it shows in our rates of heart disease, fatty liver, our weights, and even things like diverticulitis. Plenty of fiber makes the gut microbiome happy. There's just starting to be really interesting research showing gut microbiome is probably running the whole show. And some really interesting research into psychobiotics, which are foods that are naturally contain prebiotics and probiotics, not supplements, but foods that directly impact mental health. Movement, all kinds of movement. You need some of the sweaty stuff, that's for your cardiovascular system. That's the circulation part. Weight bearing and resistance training, that's for your bones and muscles, and stretching exercises, that's for your joints. American Heart Association says 150 minutes each week. That comes down to about 30 minutes most days. Do it, don't do it, do something. I love to recommend exercise snacks. I just did 2 laps around the building before this to clear my head, but even just a couple minutes here and there, walk around the parking lot before you get in your car. Do 10 jumping jacks if he does, no one's looking. Work on stress. This is actually huge and has a huge impact on circulation. Play, get outside. We're so lucky to be on the Cape, it's so beautiful. Meditate, really potent. Hard at first, even just a minute a day helps. Breathing exercises, anything that focuses your attention on breathing helps stress. And we're going to do one all together right now. I'm going to teach you how to do box breathing. It's a box because you're breathing in for a count. We're going to do a count of 4. You hold the breath in for a count of 4. You let the breath out for the count of 4, and you hold the breath out for a count of 4. That's your box. We're going to do it all together now. Here we go. Inhale, 1, 2, 3, 4. Hold for 1, 2, 3, 4. Let it out. 2, 3, 4. Hold it out. 2, 3, 4. That was so nice to see everybody do that. Do that. It takes seconds. It's free. You can do it any time of day. It works. It really helps. It activates the parasympathetic nervous system rather than the sympathetic nervous system. So we go from fight or flight to arrest and digest. I'm talking to you, all my friends with IBS. Got me? Sleep. Get some sleep. Get the TV out of the bedroom. Turn off the screens before sleep. Bed is for sex and sleep only. Alcohol impairs sleep. Sorry. And then a word about alcohol. It is linked with breast cancer, even small amounts. It's a chronic bladder irritant. You're going to be peeing all the time, and that can also impair sleep, and it's associated with a risk of increased risk of dementia. Putting it all in perspective, we're new to living this long. This is really new. And we have to understand, and that we don't really ever talk about, there are long-term consequences to living in a low hormone state. You'll be using your pelvis much longer than your forebears did. Pelvic health is linked to mental health, physical health, financial health, but it's shrouded in invisibility, and invisibility hurts. People, patients, doctors, medical providers, undertrained and uncomfortable with anything pertaining to women's pelvises. You have to be your own advocate. And we have to use language. So that's why, we're here, we're doing this, we're talking about it, we're using the language. Because that reinforces the idea that pelvic health is part of health, because it is. So I'm going to send everyone home with a pelvic prescription. a fruit, a vegetable, a walk, a box breath, an anatomical conversation with a friend or a healthcare provider, and a mirror. Look down. This is what I want you to see. Thank you very much. I think we can do some questions if people have any questions. Step right up.
I found the UTI information interesting because my mother died from UTI, 89 years old, and she had about 4 or 5 sequentially. And I remember when she was in the hospital, because she kind of fell on the floor the next day. The doctor said she had a terrible UTI. He said, and I hit her hard with antibiotics. And that was the end of it.
I'm so sorry.
It's been a long time.
Yeah.
But it's interesting about the UTI
Yeah.
issue.
Yeah.
And the GSM, just so I understand that is there's something about the digestive, your gut biome with UTIs are sort of.
No, there's a vaginal microbiome and there's a gut microbiome. The gut microbiome does not directly affect UTIs. It's the distortion of the skin over time. There's the physical and the chemical. Over time, when estrogen goes down, the pH goes up. And the healthy protective bacteria can't survive in a high pH environment. So that's the microbiome. So you lose what we call the acid mantle because the environment is no longer acidic. So it's easier for the bad bacteria to get in there. And if you're losing skin, and you can lose a significant amount of skin there, part of its job is to cover the urethra and protect it. So if there's distortions in the shape of the vulvar skin, the urethra is kind of left with constant micro trauma of movement and getting dressed, using that more being sex, any of those things. Yeah. I had a patient just, I think, this story is so common. I'm not really kidding. The story is so common, and I hear this from, when I talk about this with patients, they bring up, unfortunately, stories similar to that all the time. And I saw someone, a new patient last week, who told me a similar story. She'd been in and out of the hospital multiple times, and so they finally sent her to me. And I said, I'm curious, can you get the last emergency room report? And I got the report and read it about, her chronic UTIs in and out of the emergency room, hit her hard with the antibiotics. And I look at the physical exam done. Guess what was not looked at, right? Yeah, one thing I want to see, did they examine her? No. And when I did, I thought, women have 2 sets of lips, labia minora, labia majora, and the vulva, hers were gone. So she was really, unfortunately, very high risk because we're not taught to look at this. In truth, in school, I was not taught to.
We have a couple of questions from our folks, so joining us online. Gigi asks, what about pellet insertions?
What about what?
Pellet?
Yuck. I'm not a fan, yeah.
Okay.
So, and I will be talking, there'll be another talk next month that's more about systemic HT, and we'll talk more about that then, but there are safe ways to use systemic HT. I don't believe pellets are one of them because they give you a ginormous dose. You can't undo it. You have to live with that, and then it eventually subsides, and the body does not like having a huge dose and then eventually drops and goes back and forth. But people kind of feel high on it. It's a steroid high from the pellets, but you can give a steady state in a safe therapeutic level, a therapeutic dose, and that can be great, but you can't do that with pellets.
Here's another quick question. I was told by my doctor that oral hormones can eventually affect liver.
Oral hormones can. And so if you're using systemic hormones, you use a non-oral form. The patch, the gel, the pessary, so you can deliver systemic hormones in a non-pill form and it bypasses your liver.
Where does estradiol fit in?
Estradiol is a bioidentical hormone, and it comes in multiple forms. So you could take it by mouth, you could take it in a patch or a pessary or a vaginal cream. Yeah, so it's plant-based, it's great, it's bioidentical, and you have many, many different doses, routes, and formulations for it.
So that is a good thing to take if to rid yourself of the or to make the GSM lesser.
Yeah, so for many, many people, just using the estradiol, yeah, vaginal in the ultra low dose form, works great. Again, slow to work. You have to use it consistently twice a week, and then you still have to wait about 3 months to see what it's going to do. What you need to know about that is the further in you get in the vaginal tissue, there's more estrogen receptors. The further out you get in the opening, there's more testosterone receptors. So depending on what's happening in your pelvis, you might be healing some of the skin and it may not be enough, but you won't know until you use it for a few months to tell. But if it's really not hitting enough of the receptors, enough of the skin won't heal, and you probably need something that contains a little bit of testosterone, again, in a super ultra low dose that doesn't go into your bloodstream.
That's interesting because when they subscribe it to you, it comes with an applicator.
Yeah, I know. I tell
And
people,
they-
throw it out. I tell people it's a medieval torture device.
Okay.
How many of my patients have heard of it? Throw it out.
So
Yeah.
that's what they said, do not use it, but I'm wondering, like, you know, how far in is it in enough, you know, that. kind of
Yeah,
thing.
yeah. And the
You don't
question
have
is, you can kind of, that's the beauty of the cream, and you can use it internally and externally. So if you feel, and you're going to tell you, if you feel like you need it further in, put it further in, either with the applicator or with your finger. I think the applicator is terrible. It takes 8 hours to clean. You lose medicine in there, so I tell people don't bother with it. But with the cream, you can apply it all around the outside too, and you should.
That I never knew.
Yeah.
Okay.
Yeah.
Thank
Other
you,
questions?
thank you.
Yeah. Anything else online, Harry?
Let's see, there's a follow-up question about the pellet question, I guess. What do you need once you get injection, I guess, of the pellet, that you can't take it back? I guess.
You can't take it out, yeah. So unlike, you know, if you're taking hormones by patch or by mouth or even by cream, stop using it and it goes away within a day. But with a pellet, it takes many months for that dose to subside. You can't undo it. It's an injection. So you just have to wait it out, yeah. Anything else? Or anything else online?
No other questions online.
Okay, so I guess we'll finish up. Thanks for coming to the pelvis party. Some good resources here. I've got cards here. I don't think I even mentioned, yeah, in fact, it said Cape Gynecology, if anyone would like to come see us. Thank you, guys.
So thank you so much, again, Jaymie. I think, like I say, a lot of this information is not made accessible or easily accessible in other forums or what have you. So it's really great to have the opportunity, especially with the UTIs and what have you. And I've heard too about the high incidence of UTIs and how it can lead to, as you mentioned, people ending up in nursing homes and what have you, because it's not properly diagnosed, it's not properly treated. So I think awareness building, you know, first to recognize an issue and build awareness. So I thought it was a great presentation, and we kind of started talking with Jaymie about perhaps having her back. And something that starts talking about the process earlier, you know, for these 50s during perimenopause and before menopause, so really over the whole lifespan. But so once again, thank you very much. And if you have any follow-up questions or what have you, you can contact us here at the COA and we can put you in touch with Jaymie. But thank you. I think it's a really great and very helpful and informative presentation. And thank you so much again for joining us this afternoon. Thank you. Thank you.